Good evening. My name is Jared Rigo, and I serve on Congressman Lamborn's staff and will be serving as the MC tonight. Thank you very much for taking the time to come to the Community and Military Preparedness in Response to Ebola public information session. Tonight's meeting is not a policy discussion. Rather, it's an opportunity for civilian and military leaders to reassure the public of robust steps being taken to prepare for the potential of Ebola in the Pikes Peak region. We will be hearing and receiving presentations from 8 different speakers covering the depth and breadth of the measures being taken to protect our community from the threat of Ebola. The speaking order will be as follows. Congressman Doug Lamborn, County Commissioner Peggy Littleton, El Paso County Public Health Medical Director Dr. Bill Letzen, Commanding General Fort Carson, Major General Paul LaCamera, Commander Evans Army Hospital, Colonel Dennis Lemaster, Commander 10th Medical Group and Senior Manager, Colorado Springs Military Health System, Colonel Walter Matthews, Penrose ER Physician and Plains to Peak Regional Emergency Medical and Trauma Advisory Council Director, Dr. Stein Bronsky, and from Northcom, Colonel John DeGoes. Thank you as well to the following individuals for attending: COO Memorial Hospital, Colette Martin, Penrose Hospital Emergency Preparedness Manager, Lauren Schroeder, El Paso County Department of Health Director, Don Martindale, Sheriff's Office Commander of Emergency Services, John Padgett, City Office of Emergency Management Director and Deputy Chief of Staff, Brett Waters, Colorado Springs Military Health System Ebola Working Group Leader, Lieutenant Colonel Chris Jarvis, 4th Infantry Division Fires Coordinator, Lieutenant Colonel Keith Gerolomick, 4th ID Chief of Protection, Lieutenant Colonel Eric Sayer, and 4th ID Division Surgeon, Lieutenant Colonel Rob Price. To fully respect the time of yourselves and our presenters, there will not be questions and answers during these presentations. However, the presenters will be available for one-on-one questions at the conclusion of the public information session, and they encourage you to visit the information table near the entrance to collect important and informative materials. Ladies and gentlemen, it's my privilege to introduce Congressman Doug Lamborn.
Thank you, Jared. And I want to thank the public and the press for being here, both in person and those of you who are watching as we stream this live. Ever since I got word that the 615th Engineer Company from Fort Carson was going to be deployed to West Africa to fight the Ebola crisis, I wanted to make sure that I found out as much as possible about how our men and women in uniform were being trained, equipped, and prepared both to do their mission safely and to keep their own health in safety. And I wanted to know that just not for myself, but also for the community, for the men and women of the 5th Congressional District. So in this day and age, people need to have the facts. And if they don't have the facts, they may speculate. So it's so important when something of this gravity is taking place that people in the community have as much of the facts as possible. And that's what tonight is all about. This is going to be a public information meeting where as much facts as we know today are being given to the public. The 170 men and women who are in the 615th Engineer Company are in our community today. They'll go to Africa and then they'll come back and be in our communities and among their families and our families when they return. So it's just so important to know that they have the best possible training and preparation and protection. I've had personal meetings with General LaCamera, the commanding general at Fort Carson, General Jacoby, the commanding general of Northcom, and local leaders, many of whom you will see here tonight. And I don't know about other communities around the country, but when I see the cooperation and the coordination and the preparation, both on the military side and on the civilian side, here in the Pikes Peak region, I am being reassured that everything that's humanly possible to be done is being done. And I sleep better at night knowing that. And this exercise of people coming together is good because it's shown that there are some things where maybe better cooperation was possible, and that's being already accomplished and planned for. And let's hope there is no Ebola incidents here in the Pikes Peak region. But this cooperation and this training, this learning and working together will pay dividends in the future as well. So you'll hear in the next hour about the efforts that are being taken on the civilian and military side, and you'll see the kind of cooperation and coordination that I think makes the Pikes Peak region a really special community. It makes me proud to be a member of this community. This won't be a discussion on the national policy behind the military and civilian approach to Ebola. There's enough time to do that in another time and place. Rather, tonight will be a time to share information and for everyone in the community to learn how the professionals, both in the military and in the community, are preparing to treat Ebola and attack it as safely as possible. In the days and months ahead, let's let our thoughts and prayers be with those who are being deployed over to Africa and for their families. We'll also hear from Northcom. You may know that there's a 30-person team that's being put together to give backup to civilian authorities should the need arise. And there's even a connection between this team and Fort Carson, and you'll hear a little bit more about that a little bit later this evening. Everyone involved has been so helpful. I've been impressed with the cooperation and the sincerity and the commitment and dedication of everyone involved. It just warms my heart to be part of this community where there are so many great institutions and individuals protecting us, protecting our health and protecting our safety. So I want to thank General LaCamera for being here tonight and his team, General Jacoby and his team for participating. I want to thank our hospital systems, Memorial and Penrose, for being here. And I want to thank El Paso County. El Paso County has some dedicated professionals that you're going to hear from tonight. And you're going to also hear next from County Commissioner Peggy Littleton. She's the military liaison from the Board of County Commissioners to the military, and she's played a key role in this whole effort as well. So now I'd like to turn it over to Commissioner Peggy Littleton.
Thank you, Congressman. Thank you, Congressman. One of the things that I wanted to let you know about is that our Board of County Commissioners, back on September 23rd, did a proclamation letting the military know how important they are to us here in El Paso County, and that we value and understand that we have really the hub of national security right here in our backyard. And it is of grave interest to us as citizens to know that they are going to be safe, their families are going to be safe, and that our citizens are going to be safe. And I want to thank Congressman Lamborn for co-hosting this tonight because I receive, like he does on a daily basis, phone calls, emails, texts from concerned citizens wondering what it is we're going to do. How are we preparing? And so with us coming forward with this information session, it's really to calm fears. We become less fearful with those things that we know about when we're able to ask questions, when we're able to discuss. While we're not going to have any questions or discussion tonight, it can be the beginning of us having the conversation to email either myself or Congressman Lamborn or any one of our military leaders that if you have questions tonight that go unanswered, let's continue that because this is a continuously evolving situation. We do not know all the answers at this point in time, but we are going to at least take the opportunity to disseminate and discuss the information that we do know. One of the things that we do know is that we don't get good at those things that we don't practice. And so I am very comforted, and you're going to hear some of it this evening, that some of the protocols, processes, and procedures that need to happen to make our community safe and secure are happening right here in El Paso County. I've been working with Bart Howard, the City Office of Emergency Management Deputy Director, and Bart's here, and also with John Paget, who is currently our El Paso County Office of Emergency Management Commander. And we've been working collaboratively along with them and our hospitals, our military, to make sure that we know if AMR shows up with a home who has a patient who's called in who's exhibiting symptoms of potentially an Ebola type of virus, that they know how they would deal with that. Do we have a special ambulance that could actually contain and not infect the drivers of AMR? Are our hospitals set up? Have they drilled the practice of where that ambulance would park? How would we transport the patient? How would we put them into a contained room that is in isolation? Do we have those rooms set up? How much toxic waste are we going to have? What do we do with the toxic waste as far as incinerating or putting it in an autoclave to make sure that we reduce and minimize any risk to our constituents and citizens here in El Paso County? And so with that, we've got a wonderful host of speakers lined up to give you some data and information and facts to the best of their knowledge. Do we know everything? Not yet. But let's begin the discussion tonight and at least allay and put down some of the fears that the public may have. Because what we want to know is that we have a community that's going to be a community that thrives. We're going to want to ensure our economic sustainability and viability. We want people not afraid to go out and go to work, to go out and go shop, to send their kids to school, to have our service industries be able to go out and pick up trash, to do the electrical repairs in your home. We want to have a community that feels very safe and secure, and we're going to try to present that this evening to the best of our ability. Thank you so much.
All right, thank you. First up here on our presenters is going to be Dr. Bill Letson, the Medical Director for El Paso County Public Health, with a presentation entitled, "What is Ebola and what is the risk to you? What's the local public health's role in reducing that risk?" Dr. Letson.
Well, thank you, Congressman Lambourne and Commissioner Littleton. I think the first thing I would say with regard to Ebola, just to start this off, is that people in the community can feel quite safe in going shopping and all of the other sorts of things that Commissioner Littleton was talking about. Wrong button. There we go. What I'm going to do is start off just by telling you how public health functions in general, because it really is the model for how we are functioning with regard to Ebola. And we are responsible for monitoring, along with the State Health Department, some 60 reportable infectious diseases, including some others. And this is something that goes on 24/7. There's always somebody in the communicable disease unit at El Paso County that's carrying a mobile pager. And the purpose of this is to identify anything that might be a threat to public health in the community. Then by talking to people with an identified disease, talking to people who they've been in contact with, we are able to sort of go out into the community and limit the control of spread of disease in the community. We do this with a number of things, and I've just put some examples here for you. For example, influenza, which is going to be on us rather shortly. Other examples of vaccine-preventable diseases are measles, whooping cough. And then, in addition to those 60 reportable conditions that I mentioned, we're always involved in the business of emerging infections. And there are some prior emerging infections in the form of West Nile or H1N1 pandemic variety of influenza back in 2009, which have now sort of become part of our regular makeup. But we were very involved with both of these when they first appeared on the scene in Colorado. Enterovirus D68 is something new that people have been hearing about circulating this year in children. And then finally, Ebola. And I'll begin, the rest of this is about Ebola, and basically here is what Ebola looks like from a clinical standpoint. To begin with, the sorts of things that you will see with Ebola are very similar to what one would see with influenza. That is, these first four symptoms on the top, fever, headache, stomach pain, muscle pain, those are common to both entities. After that, they begin to diverge. People with influenza can have a bit of diarrhea and vomiting, but it's usually mild, not much of an issue. With Ebola, some 80% of patients will have diarrhea and vomiting, and it's severe. That is often what kills folks. They basically die of dehydration and or of complications of hemorrhage. Where they begin to really diverge is actually with regard to the respiratory component. Influenza is a respiratory virus. That is, it really inhabits the lungs and, you know, from the nasal passage on down, the whole respiratory system. People with influenza will eventually start coughing because it's primarily a respiratory virus. And influenza, like measles, things of that sort, can spread by the airborne route. You can cough, and viruses will come out in a fine mist, and particularly with measles, you can infect people within a 30-square-foot space if you have measles, which inhabits the respiratory tract. Ebola does not inhabit the respiratory tract, and therefore is not transmitted in an airborne fashion. And I think that's one of the main messages for people that have been given publicly, and we're going to give it again here tonight. This is not an airborne transmission type of an agent. It's a bloodborne pathogen. And I guess that gets to the point highest up here on this slide. We don't concern ourselves with airborne transmission. In addition, this is not a virus that we have to worry about with regard to waterborne transmission. It lives in the blood, which is a very salty environment. So if the virus gets into standard water, which is not salt-laden, the water will basically kill the virus. After that, there's chlorine and in the water that will kill the virus all over again. And finally, household bleaches, chlorine preparations will also kill it. In general, you also can't get it from food. There's an exception to this, which is kind of important in terms of everything that's been going on. That's that it is thought this virus, which is primarily a virus that lives in animal reservoirs, probably gets started in or gets into humans by virtue of people hunting either monkeys or very large fruit bats in Africa. That's really the only way that food is an important transmission source. So where is this infection currently? Some of this you already know, and I'm going to apologize. This is also fast-moving, that there's some information on these slides that's already a bit dated. But this infection is being circulated in 3 countries in Africa: Liberia, Sierra Leone, and Guinea. Now this case count is up to about 14,000. These are the areas where it's circulating. And this map is also dated only in the sense that the orange areas, which reflect the areas where there's been infection, are somewhat larger now, particularly in Guinea. And it is thought that this whole thing started in a 13-year-old boy who had gone out, hunted a fruit bat, killed it, basically got contaminated in the process of handling the bat, and then took infection home to his family, and then it has spread sort of across both of these borders, the Sierra Leone and Liberia. And an important thing to know about these 3 countries is that they've got really poor health infrastructure, have had for a long time. They've been in some form of civil war for roughly 2 decades until fairly recently. So whatever infrastructure they had has really been wrecked. And it is thought that that's why this particular outbreak has gotten so large. In another country not too far away, in Nigeria, the virus was transmitted, actually, I think from a Liberian who flew into Lagos, and that outbreak was stopped as we usually stop it, and as we are doing so right now in the United States with normal containment within hospital and within the community. It stopped with 20 cases. It's been way, way beyond a very important number I'm going to give you now, which is a 21-day figure, and I'll explain what that's about. If one gets infected with this virus, it takes roughly 21 days at the furthest to develop disease. 80% of people will develop disease within 8 to 10 days. So it's the worry zone is mostly over with in a little over a week. But 21 days is the outlier. We know the outbreak in Nigeria is done now because we're well beyond the 21 days from the last case. So the United States, this is probably what most people are interested in and why people are here tonight. What we have had so far is a total of 8 cases of Ebola within the U.S. As you can see, 6 of these were actually infected in West Africa and brought to the U.S. for treatment. 4 of them were healthcare workers. 3 of those are free of the virus out of hospital. The one who is not yet is a fellow who was just identified in New York recently and is currently being treated. One reporter acquired the virus, also now treated, free of the virus, out of hospital. The Liberian that's listed up there is the unfortunate fellow who went to Dallas, and he is the only fatality so far in the U.S. He infected 2 nurses, which I'm sure you've all heard. They are both now treated, free of virus, and out of hospital. The contacts listed up there are contacts of Mr. Duncan in Dallas, kind of in the first wave that he exposed either on September 27 or 29. Those people are now past the 21-day period and do not have infection, and that includes actually the people that were living in the apartment with him. And there are roughly another 50 people who were in contact with him in the time period from which he entered the hospital to when he died on October 8th. They should clear today. I've not heard anything on the news, so I suppose we'll hear the announcement tomorrow, but there's been no word of infection in any of those healthcare workers. What can people do? I'm going to brush over this quickly because it's a lot about what you can do in general to protect yourself against all infectious diseases. The top on the list, getting vaccinated, go out and get your flu vaccine. I'll put a plug in for that right now because that kills 1,000 to 3,000 people every year in the United States. It is not possible to do that with Ebola yet, although there is work overseas on vaccines currently. Hand hygiene, staying home if you're sick, basically using bleach types of infectants, and the last item, which is what this meeting is about, is just stay informed. Basically get the facts on things like this. This is sort of a messy slide, but it shows you the network that we at Public Health work with, not only on Ebola, but on all infectious diseases, particularly emerging infectious diseases that in some way become threatening. With regard to Ebola, we have been in contact with the State Health Department, CDC, local hospitals, labs, local physicians groups, emergency managers, first responders, all of the people on this slide, basically trying to help coordinate efforts and do a role that we have, which is assurance that all of that is ready to go. We don't have control over all those things, but we can work with all these partners to try to be certain, in conjunction with the State Health Department, that everything's set to go. The other way in which we are involved in this, you all know that there are a certain number, not a large number, but about 150 people a day that come in from West Africa into the quarantine stations. They're all coming into 5 airports in the U.S. where they're quarantine stations. They're screened there by people, and then if someone is identified as being from one of those countries, CDC notifies the state that they're going to. The state then notifies us, and probably by the end of this week or early next week, we will have a role in monitoring these people in the way that's shown on the slide. It's basically there will be daily face-to-face monitoring in which we'll observe them take their temperature, note that, take a list of symptoms, looking for symptoms of Ebola, and then there will be a second telephone contact later in the day going over the same issues. A few people who are at extremely low risk, say for example they were in a room with someone but they had protective gear on, and we're never any closer than across the room, those people will probably just be monitored by telephone contact. And the last thing I want to share with you is this, which is just a series of references for people to look up. And I think these slides are all available on the table up here. At least this is. And it's got the El Paso County website. The middle one is the State Health Department website. The bottom one is the CDC website. And basically all the information I'm giving you and most of the information that we operate on locally and at the state level can be found at the CDC site. They are the primary reference. And then finally, this co-help line is a line at the State Health Department. It's an 800 line that people can call if they have particular questions about Ebola. And they have a series of telephone prompted frequently asked questions that people can go through. And with that, I'm done.
All righty, thank you, Doctor. Next up, we're going to hear military mission updates and medical response plans from 3 officers. First up, Major General Paul Campbell.
Yeah, thank you very much, and thanks all for attending tonight and giving us the opportunity to speak to you. We are preparing to deploy soldiers from the 6th 15th Engineers to West Africa to build living and work facilities for personnel supporting the response mission. Additionally, they will improve routes to enable travel for USAID to the contaminated areas. We also maintain a persistent or consistent presence throughout Africa in multiple units that are assigned to Fort Carson, 10th Special Forces Group, 71st EOD, and others that do conduct operations or training inside of Africa. Please know that we're doing everything possible within our resources to prepare these soldiers, their airmen, and their families for the upcoming deployments, and continue preparations for deployments of the soldiers to the installation, from the installation, and then obviously when they return back, and make sure that they come back to Fort Carson, but not only Fort Carson, El Paso County, and in the local area. Today, the Army or the Secretary of Defense directed a 21-day quarantine period. And then the Army Chief of Staff announced the Army Chief of Staff has directed a 21-day controlled monitoring period for all redeploying soldiers returning from Operation United Assistance. The Army is assessing possible sites for the controlled monitoring. No decisions on the locations have been made at this time. Fort Carson's priority remains the preparation of our soldiers, their preparation for the deployment, but also it remains for ensuring the soldiers, the family members, and our surrounding communities are protected as we bring them back home. And I'll close before I hand it off that we are committed to the full transparency of what's going on. As problems or challenges arise, we'll solve them as they come, and we'll make sure that we keep everybody informed. Thank you.
Thank you very much, General, and thank you for being here. Next up, we'll hear from Colonel Dennis Lemaster, the commander at Evans Army Community Hospital.
Good evening, and thank you for coming tonight. I'd like to open up with the statement that Army Medicine is committed to sustaining the health and safety of our soldiers, family members, retirees, and of course, the local community as well. Army Medicine's focus is centered upon preparing our soldiers, protecting our soldiers, returning our soldiers, and as we go through that, reassuring our families. Necking it down locally to where we are at Evans Army Community Hospital, we are aligned with the latest DoD, Army, and MedCom guidance, and I want to put out that guidance is evolving as we understand the disease more as time goes by, so we will adjust as necessary. Evans Army Community Hospital is coordinated and synchronized with the Colorado Springs DoD multi-service market, and Colonel Sparky Matthews to my left will talk more about the market response here in just a moment. But in a nutshell, that is our integration into the healthcare system delivered by USAFA, by Peterson, by Schriever. We're all one team on this. General Camera talked about the 21-day controlled monitoring policy, and we'll be aligned with that as the soldiers return back from Western Africa. Where that will occur, we don't know yet, and that is being studied for the most ideal location. Key takeaway here this evening is that Evans Army Community Hospital will not be treating an Ebola patient. Will not be treating an Ebola patient. If anybody has Ebola, it somehow makes it through all the wickets of screening and monitoring on their pathway back from West Africa, the remote possibility that would occur, that patient would go to one of the 4 CDC hospitals, and let me outline those for you. The National Institute of Health in Bethesda, Emory University in Georgia, University of Nebraska at Omaha, and then St. Patrick's University at Missoula, Montana. That is where nationally at this point, our patients, Ebola patients, are being medically regulated to. Now, DoD has identified 4 other hospitals right now that would be kind of a second tier, if you will, of hospitals in the event that the capacity is filled up at one of the CDC facilities. And they're Portsmouth, Wright-Patterson Air Force Base, WOMAC at Fort Bragg, and then Walter Reed, which we are familiar with. Let me talk briefly about our local posture and where we are right now, and I want to talk this from the context of equipment, training, facilities, and exercises. Lots of discussion at the national level about personal protective equipment, which I'll refer to as PPE, just because it's easier for me to say. But right now we have over 500 sets on hand, and we've had actually that PPE on hand for a while now. We're getting more sets in as they come, and those sets are in compliance with the latest DoD guidance of the specific types of sets that cover the entire body so that no skin is exposed. The lab equipment, which we can use to do isolated testing of specimens at our 2 nodes within the hospital, has arrived. That way we can keep the specimens in the isolation rooms and not have to traffic them through the hospital to our lab and spin the tests there. One of the things we've learned as you put on these suits is they're very hot, very sweaty. Your eyepiece fogs quickly. What we didn't know, what we learned, is this device called a PAPR, which circulates air, kind of like a mini air conditioning system. We have enough for those sets, so you plug that in, it's battery operated, and it circulates the air and takes the fog out, kind of like defrosting a windshield, if you will, and adds a much greater degree of comfort for the clinicians operating in those suits. Since, I mentioned that we're integrated into the market, we also have to respond within Fort Carson. We have a designated ambulance that we will use to transport an Ebola patient, or suspected Ebola patient, I should probably say. And essentially that thing is lined with a huge plastic sleeve in the back, has enough sets of PPE for the crew of the ambulance to don the equipment, drive to work, pick up the patient, return them back to Evans. Now afterwards we would have to have that ambulance decontaminated and then re-sleeved again with the plastic and get it ready to go again, probably a several-hour turnaround time, about 8 hours or so. One of my great concerns is the management of the hazardous waste. What I've heard, the gentleman that passed away in Georgia, Dallas, roughly 10 liters of bodily fluids, 3,000 pounds of hazardous waste. And that is something that has to be managed very, very well. We have a 20-foot mill van that's spotted behind the hospital, which arrived the other day. We have installed a second set of cyclone fences to add an additional layer of security so no one can accidentally stumble into this mill van. So there's 2 locks. And essentially the hazardous waste flow would go from a red special bag in the treatment room to a special red sealable bucket, plastic bucket, and then would be taken to and that is disinfected and decontaminated before it goes out of the room to the mill van, the large container, and then we have a contractor, Stericycle, which will pick up the waste, carry it away to a state permitted to burn, to incinerate, and dispose of it that way. So that addresses equipment. From a facilities perspective, we've identified a room in the emergency department, and it's designed, it fits within the facility such that we can bring a patient in without them being seen by those in the waiting room, and kind of maintain some discretion. And this room, it will go in there. It's already been sealed with the appropriate material, and it has the ante-room where the clinicians can change into their PPE, and we can keep the patient isolated, and along with all the associated equipment. We also have another room in the ICU where if we had to hold a patient for 48 hours, and at the outset, another 2 days in our ICU, and that room is all prepared as well with the ante-room, with the bathroom, et cetera, so the patient has some degree of comfort and the clinical staff is safe. From a training perspective, for the last 3 weeks, we've been working at a market level on how we're going to deal with a possible Ebola response, and I'll let Colonel Matthews address that. But locally, we've done significant training with how to don and doff the PPE, and Military folks tend to be very impatient. They want to get out of this cumbersome stuff. What we're learning from those treating patients in West Africa, they take about 50 minutes to get out of it. And they do it with a buddy, and they do it very deliberately so that there's not a spread of bodily fluids that could possibly make someone ill. We've also done training with our clinical staff, those on the front line of medicine, if you will, on protocols and a screening criteria as well, and also how we would manage a patient. Also, just as another precaution, we have a decontamination team. Our decon will be done by a contractor, but just in case, extra level of caution. We broke out the equipment, we've assembled a team, we've tested the equipment, patched the mouse holes, and we're ready to use that equipment as well. From an exercise perspective, and I'm speaking, that was individual training, but now let me address organizationally what we've done and what we're going to do. We had a tabletop drill several weeks ago where we had a scenario and we just talked through it. All the leadership did. And then what we did following that, we got the concept down. We had what we call as a terrain walk. It's an inspection, if you will, walking the actual terrain, the facility where a patient will arrive. We'll have them park in the parking lot all the way through the emergency department, which hallway, which elevator we go up, and assuming that, because one's always broken, that elevator will be broken, what the backup elevator is, the route of march, travel to the ICU, et cetera. And things emerge from that, and you learn about where your shortfalls are, and you identify your gaps, and you correct your gaps, whereas to properly put the equipment, et cetera. Then we had, last week, we had a patient which presented, which really served as a good training exercise on the decision-making and the intellectual drill, which goes through managing a possible Ebola patient. Patient did not have Ebola. Patient was discharged, make that clear. But it exercised our command and control, our reporting to multiple different headquarters, and we had a great opportunity to do an after-action review and learn from that as well. Tomorrow, in coordination with the Fort Carson Garrison, we're going to do a small exercise where we're going to have a patient present at our Soldier Readiness Center as a redeployer, and we will have to go to that building with our ambulance, pick him up, and then bring him back to the hospital and go through our treatment protocols. And then next week, we're going to do a market level drill with a patient presenting at the academy and another patient presenting at Peterson, and work that evacuation piece as well. Let me briefly go through just the flow so you get a feel for how it would work. Patient presents, we have signage up, and we really made it hard for the patient to miss the signage. And they're instructed to go back to their vehicle, call the ED. Our team will come out, mask them. The team will be in the proper suits. We'll bring them into the ED, where the emergency department, where they will be screened. And then if they meet the screening criteria for possible Ebola, we'll take them up to the ICU, where we will do tests. Now, we kind of have a threshold to cross. When we decide to test for Ebola, when we draw that blood, that triggers a response from the CDC on how we test that blood. That blood sample will go to a 20 laboratory network, the Laboratory Response Network for testing. And we should get a result in about 2 days, 48 hours. There may be the possibility that there's a false negative, so we're going to do another 2-day test. If it's a negative test on both iterations, the patient's sick with something else. If the patient does test positive for Ebola, the patient's evacuated by a contract carrier called Phoenix Air, and that carrier will take them to one of the 4 hospitals I talked about earlier. Okay. We've been communicating this with our staff, training our staff, 2,700 employees, so we have a lot to cover. We've been doing this very deliberately the last several weeks, this week, and we'll continue on. Final point I'd like to make is just to reiterate that Ebola patients, a confirmed Ebola patient, will go to a CDC facility. And we're taking every precaution. We are looking for Ebola, as are other hospitals in the Colorado Springs area and nationally. We're taking every precaution to ensure the safety, health, and welfare of our soldiers and their families. Thank you for the opportunity to comment.
If I could just address one redirect that Colonel Master talked about with the training that's ongoing. So our soldiers are going through that. So you may see pictures of them in the gear as we train up for it. So the retraining for this will happen using the protective equipment will be on the 3rd of November. As he's going through this exercise, they'll be moving around the post. It will be an exercise, much like we notify the public of live fire training, and there'll be, additional noise and whatnot. This is what's going on. I can anticipate as this continues and we have to continue to send soldiers downrange, that we'll do training to make sure that we maintain this. We'll make sure that we notify the community that this training is ongoing and that it is an exercise and it's not a reaction to something that actually has occurred. So that's just to keep people informed that if you see them running around in our mop gear, for example, that there's not a chemical attack. This is just normal training that's ongoing and realizing everybody's sensitized to this threat. Thanks.
Thank you, General. And next up, we'll hear from Colonel Walter Matthews. He's the commander of the Air Force Academy's 10th Medical Group and the senior manager for the Colorado Springs Military Health System.
All right, thank you very much. Good evening, Congressman Lamborn and Commissioner Littleton. Thank you very much for giving us the opportunity to speak this evening. And thank you very much for coming to here this evening. As was mentioned, I'm Colonel Matthews. I am the coordinator for all of the military medical care in the Pikes Peak area. So I work very closely with Colonel Master and Colonel Moran at Peterson to make sure that we approach medical care in this community from a unified stance. And we're approaching our preparations for Ebola in exactly the same way. So my intent this evening is to explain how the Department of Defense is protecting our military members that deploy into Ebola outbreak areas in West Africa. And the reason this is important is because as we protect our military members, we are protecting our communities that they live in as well. So our protection of them is protection of you as well. So if I could have the next slide, please. All right, so the overarching goals of the Department of Defense process is to train and equip our members to prevent exposure, to identify and monitor members that may have been exposed, to treat members that are showing symptoms, and to ensure that exposed and sick members do not return to their home community until they are assured to be disease-free. And so what I'm going to show you this evening is a condensed version of the DoD process for what we do before deployment, during deployment, and after deployment for our soldiers, airmen, sailors, and Marines that are going into West Africa, into the Ebola outbreak areas. So what I want you to keep in mind about this is that we have an exceedingly robust screening process for our in-country deployers. It's redundant, it's very conservative, and it's intended to identify members who have been exposed and to what level they have been exposed. And so you'll see on the slide that before deployment, when our folks are identified to go, we give them education and training based on their expected exposure level. So if you have an individual that is going to be building a hospital, not expected to be exposed at all, they might get level 1 or level 2 training. Depending on their potential, they may get a higher level of training. They also receive and train with the equipment for operating in that deployed location. You heard Colonel Master speak about the personal protective equipment. Well, we send our soldiers with that equipment into the theater as well, and they train on that equipment and receive the equipment they're going to use before they leave. So then they head out to Africa, and during the deployment, every single military member that is in the Ebola-exposed area has twice daily, face-to-face temperature and symptom checks. Every single military member, every day, twice a day. Okay, so it's going to be very difficult for them to have a problem without us finding out about it. If we have an individual that reports a potential exposure, they are evaluated immediately by a Department of Defense designated medical authority, and that's outside of the twice daily screening. If a member has exposure and develops symptoms, they are immediately isolated, and then they're evacuated to a DOD-designated facility for monitoring and treatment. So they do not stay in country if they get sick or even if they have a significant exposure. And then once that deployment is over, before they come back to the United States, they go through a final screening for exposure prior to their return. And my next slide is going to explain what we do with that information that we get on that final screening. So, any exposure to Ebola results in the member being evacuated to a DOD facility for a 21-day quarantine. And what you need to know is that location where they are quarantined is not in Colorado Springs. Okay? There are several places they could go, but they do not come home to Fort Carson or anywhere else in Colorado Springs for that quarantine. If they have potential or high risk for Ebola exposure, they're transported out of theater. They do not come back with the rest of the unit. They go by regulated movement, which is essentially air medical evacuation, and they're quarantined for 21 days at a DOD facility. If they have no known exposure to Ebola for the entire time they're there, which is what we expect for the vast majority, if not all, of our engineers that we're about to send, then they come home either as a unit by military air, or if it's an Air Force deployer, maybe onesie twosie if we have a communications squadron member that's going to support the mission there, and they go by themselves and come back, they'll fly back on commercial air, and they are met at the plane or for commercial air at the gate in the airport by a DOD healthcare provider. They are given immediate education and a handout that tells them what they are responsible to do over the following 21 days. They then have 21 days of, again, twice daily, face-to-face temperature and symptom checks by a DOD medical provider. Now, I'm sure you all saw the news today and saw that we do have some evolving guidance and some evolving procedures for what we're going to do when folks come home. And the only thing I can tell you is that is almost certainly more conservative. We're not going to move to a less conservative thing that we're doing with our folks coming back. Okay, so there's one more group of individuals that we deal with, and that is our transient personnel or our air crew. So let's say we have a airlifter that is flying a C-17 from Peterson, carrying supplies, carrying personnel to West Africa. They land, they drop off the folks, and they fly back. Okay, the only interaction that they've had is with military members on the flight line. That is an extremely low potential for exposure. Consider a commercial airline pilot flying to West Africa and then coming home. That's the kind of exposure you're talking about. Those individuals will do twice daily self-checks for temperature and symptoms according to the instructions they're given, and then they'll report that back into their DOD medical provider. So, if I can go to the next slide. So that essentially talks about how we deal with and protect our military members that are going into West Africa. So some of the things back here at home. Colonel Master mentioned briefly the flow of patients within the market. Okay, if we have an individual that presents to the Academy or to Peterson or to Schriever with symptoms that are consistent with Ebola, that meet the CDC case definition, they will be immediately isolated with the same PPE protections that Colonel Master talked about for Evans. We are doing this all the same way in all of our locations. They'll be immediately isolated. We call over to the Evans Emergency Department. They send their ambulance that you saw the picture of over to evacuate that patient to the Evans Emergency Department. So in the Colorado Springs Military Health System, when it comes to potential Ebola patients, all roads lead to the Evans Emergency Department. And that is the best way to describe that. If a patient calls and wants an appointment, and every single person that calls will be screened for the symptoms and the travel history for West Africa. If they meet potentially the CDC case definition during that phone call, then we will, the individuals that they're talking to at our nurse advice line will call EMS, have EMS go to their location. They will stay on the phone with the patient until EMS gets there. The nurse advice line will then talk to the EMS provider and let them know we suspect this may be a potential Ebola case and recommend that patient be taken to the Evans Emergency Department. So we have tried to wrap our arms around every conceivable way that a patient could present in our military health system to get them to the right point of care and evaluation, which is Evans. Okay, so the Colorado Springs Military Health System has been working very closely with our local agencies, some of whom are here tonight. At the market level, we have an Ebola working group that has been meeting for over a month now, and they've attended several El Paso County Emergency Services Ebola discussion meetings so we can coordinate our efforts. Lieutenant Colonel Jarvis, who's my Chief Medical Officer for the market, has also met with the Penrose Chief Medical Officer and the Memorial Chief Medical Officer to have info sharing to get a common operating picture and to determine the possibility of sharing PPE if that becomes necessary, and that could be either direction. And finally, our Environmental Science Chief at Evans has been in contact with the Department of Transportation on the management and movement of Category A hazardous waste. So we're we are wrapping our arms around everything that we can think of when it comes to Ebola. So if we can go to the last slide. This is what I want you to take away from the Department of Defense preparation for Ebola. The Department of Defense is taking every precaution to ensure health and welfare of our service members and their families. And as I said before, by protecting the service member and their families, we are protecting our community. No service members with symptoms of Ebola will return to Colorado Springs. They will be cleared of the disease and monitored before they come back. We are actively monitoring for Ebola in every single medical encounter, in every clinic, in every facility, every provider, every patient. We're looking for this. And in every returning deployer as well. And finally, if a patient presents with new symptoms of Ebola here in the Pikes Peak area, they will be isolated and then transported to a CDC or DOD designated facility for testing and care. They will not be treated in Colorado Springs. So if we have them, we won't have them long. Okay, we're going to get them to the best care, the most concentrated care that we can have. So thank you very much.
Thank you, Colonel. Next up to hear a little bit about the county and city emergency medical response to Ebola is Dr. Stein Bronsky, who among his many titles is an ER physician at Penrose and is the co-medical director for the Plains to Peak RETAC service. Dr. Bronsky.
Thank you. Excuse me. Thank you for inviting me to speak here. I saw that as long as this pamphlet is accurate, there's some of my slides missing, so I'll go on to go through some of these and then just do some speaking. I work in one of the local emergency departments. I actually came to Colorado Springs through the Memorial system and now work at the Penrose system, so I'm very familiar with both of them and am in close contact with both of them. And I do currently medical direction for both the fire department in Colorado Springs and El Paso County AMR. And so I just wanted to reassure everybody here that we are very prepared for this. I'd also like to just back up globally and reiterate what Dr. Letson was saying at the very beginning of this, that our medical capabilities in the United States are far superior than what exists in the countries where this virus is running rampant right now. And so that should instill some confidence in everybody. I'm going to talk on two fronts. The first one is about the field response to potential Ebola cases, and then talk a minute about the hospitals. As far as the field response is concerned, and when I talk about field response, we have a dual response system here in Colorado Springs and in El Paso County, where for the most part, fire services and the AMR, which are the transport ambulance service, both respond together to 911 calls or to medical incidences and work in coordination with that. So we have been working very, very closely together to make sure that we're coordinating these efforts. In the initial response, we divide these responses up by people's symptoms. And we have the wet versus a dry patient. And the dry patient is somebody who may answer positively to some of our screening questions. And the screening questions are very simple at the moment, which are, have you traveled to one of these areas? Have you been in contact with somebody who may have been exposed? And do you have a fever? Okay, and if any of those answer positive, then we divide them up into a wet and dry response. The reason why we do that is because that's different levels of protection for the crew members. We're trying not to operate on fear, but on real evidence that we have, knowing that the real contagious patients are the ones that have a lot of bodily fluids coming out of them, like vomiting, diarrhea, etc., and that puts people at a higher risk. And so those are considered the wet patients. For the dry patients, we have a standard contact droplet precaution, which is up to date with the current CDC recommendations. I'll show you what that looks like. For the wet patients, we have Tyvek suits with the PAPRs, and as one of the commanders was mentioning, those are the personal respiratory devices, et cetera, that are within the suits so that people can stay in them and be covered up and not sweat themselves out in just a couple of minutes. We do have the AMR regional wrapped ambulance is the way that we call it, which it looks almost exactly like the one that was pictured from the military. This is a vehicle that sits aside right now, has been completely wrapped up and prepared for an Ebola transport, and is not used in the regular theater right now. And all of all unnecessary medical equipment has been stripped from that vehicle. As I said, the fire departments and the transport agencies respond together, and we will have, if need be, the hazmat teams from the fire department responding with the AMR units, and it will be decided on a case-to-case basis what level of protection is needed and how those people will be extracted from their environments, put into the ambulances, and then brought to the hospital. And so that is something that does take some time and effort, and it's a point that I want to make that that when we have identified a person of suspicion, or at that point, they won't actually be somebody that's been diagnosed because we don't know that yet. But when we have identified somebody that's a person of suspicion, we will delay the response as much as we need in order to prepare everybody correctly. That doesn't mean that we don't respond. It just means that we can step back, we can organize. We don't have to be pulling that person out of their environment within 8 minutes or 10 minutes or 12 minutes. We can make sure that all the crews are properly donned in their PPE, and then make sure that they are safe so that we are not potentially spreading this any further. If you go to the next slide, this is just a picture of the personal protective equipment that will be provided for the crews on a dry patient, which is considered a patient that is low risk. Okay, and it is pretty extensive. It consists of a suit and a hood and booties and a face mask, as well as an underneath mask, and then 2 sets of gloves. And then on the next slide, you actually see the upgraded PPE for the wet patient, which is the same Tyvek suit, same gloves, same booties, but then what we're doing with is the encased hoods and the PAPR devices, et cetera, which give you more protection. Local AMR actually has gone one step further, and we do have 8 Tyvek suits that are completely impermeable, that are actually more of a protection than what's pictured here. We are lucky to have those because that's something that had already been distributed to us actually several years ago as one of the centers for the Front Range AMR. And so we have those in town. They sit with us, and actually if Denver or Pueblo or the entire region would need a response with those, they're going to come from Colorado Springs, and we have those right here for us right now. And so we are very confident that we're protecting our crew members and therefore passing that protection on to the health workers that are going to be taking over these patients. On the next slide, the way that the transport works is that on the scene, the crew's supervisors will be talking to the designated hospital that the patient will go to. The hospitals here in the community are prepared to initially take in Ebola patients. Every one of them could take in a walk-in patient. We've designated certain hospitals that are prepared to receive the ambulances, and there's been thorough dry run-throughs with this to go through every single step of how the ambulances pull in, who's going to be coming into contact with them, how they're going to be extracted from the ambulances, how they're going to enter into the emergency departments, what rooms they're going to go into, how those rooms are going to be prepared, how those rooms are going to be staffed. Okay? And as far as I mentioned one thing about regional response before I go back to the hospital, which is that AMR is developing a regional response team. That team will be available not only for Colorado Springs, but it will be available for the greater region all the way down into northern New Mexico, et cetera, to help out with a patient that may be identified in the field that needs safe extraction outside, to a medical facility. And so, but as far as Colorado Springs and the Pikes Peak region is concerned, in our local region, we have all those resources exactly on hand. I think between AMR being the regional base for Colorado Springs being the regional base for AMR, and with the military's capabilities, our city and our region is probably much better prepared for this than I would venture to say almost anybody else. And so to go back to the hospitals, and I do not think that these slides are here, is that the hospitals are following all of the CDC and World Health Organization guidelines, and they actually all exceed those guidelines. The reason for the exceeding right now is that the fact is we still do have some unanswered questions, and so we're being better safe than sorry. Okay, but the evidence is becoming more and more clear every day about what we do and do not need to be concerned about. And as the time goes on, we will know more and more. But at the moment, what the hospitals are doing is essentially the same as what the military is doing within their facility, where we are going to have specific rooms where these people are isolated into. They are prepared. We have specific people who have been trained up for this. The intake staff, et cetera, people that may incidentally come in contact with somebody that either walks in or is dropped off or arrives by ambulance and they were not identified. Everybody is trained up to that level to be screening with the questions, to have the initial protective gear that they need, and then it will be elevated from that point. If we know already that they're coming from the field, those people will be directed directly into these isolation rooms. And then what we've done is followed the next round of CDC recommendations, where we have special teams in the hospitals that are going to be responsible for taking care of these patients. So it's not like we're trying to train up all several hundred staff members that could ever potentially come in contact with these people. If there is an identification or even a concern, those special teams will be called in. They are on call. There are enough of them to be on 24-hour call. And they will swap out with other people who have been specialty trained, and those are the only people that will be taking care of these patients in their duration in the hospitals here in this region. And so those people are not only trained on how to don the PPE, but more importantly, how to take it off safely. And so it's all done with the buddy system. And so we feel as though there's been great coordination with this, and I think that everybody should be very comfortable with how we can handle this within our community.
Thank you very much, Doctor. And now to hear a little bit about the DoD National Response Team being run out of Northern Command, the NORTHCOM Command Surgeon, Colonel John DeGoe.
Good evening. Thank you, Congressman Lambourne, Commissioner Littleton. I'm an internal medicine physician, and I serve as the senior medical advisor to the commander of U.S. NORTHCOM, General Charles Jacoby. Our headquarters is located here in Colorado Springs at Peterson Air Force Base, but our area of responsibility is the United States, Canada, Mexico, and the Bahamas. The Defense Support of Civil Authorities Mission, or DSCA, is second only to Homeland Defense for NORTHCOM. On request, we often assist other federal agencies responding to wildfires, floods, hurricanes, and even infectious diseases such as the 2009 H1N1 influenza pandemic you heard about earlier. In our Defense Support to Civil Authority mission, NORTHCOM and Department of Defense forces are always in support of another lead federal agency such as FEMA or the Department of Health and Human Services. In response to a recent request by the Department of Health and Human Services, and as an added prudent measure to ensure our nation is ready to respond quickly, effectively, and safely in the event of additional Ebola cases in the United States, U.S. NORTHCOM, at the direction of the Secretary of Defense, has prepared and trained a 30-member medical support team that could provide short-notice assistance to civilian medical professionals in the United States. The Army, Navy, and Air Force provided personnel to form this joint team. It consists of 20 critical care nurses, 5 physicians with expertise in critical care, infectious diseases, and internal medicine, as well as 5 infection control experts. One of the physicians has extensive experience treating Ebola patients in Guinea in this outbreak. And additionally, Fort Carson's Evans Army Hospital's own Major Dr. Anthony Cooper, an internal medicine physician, is a member of this team of the military's finest medics. This team received world-class, realistic training last week in the care of Ebola patients in San Antonio. They demonstrated proficiency in critical personal protective equipment procedures, and this team is now ready in a prepare-to-deploy status, available to be sent to other locations as required. They will not be sent to West Africa or other overseas locations and will be called upon domestically only if requested by the Secretary of Health and Human Services and approved by the President or the Secretary of Defense. In conclusion, the preparation for this request for the 30-member medical support team is evidence of the strong relationships that NORTHCOM has with our federal partners, including Health and Human Services, and we will always remain in close contact to ensure we are able to anticipate requests for its assistance, or as General Jacoby says, don't be late to need. Thanks very much.
Thank you, Colonel. And before I make some final housekeeping announcements, I'd like to invite Congressman Lambourne to make some concluding remarks.
I want to thank each presenter for being here and for providing valuable and timely information to the community. And as Commissioner Littleton has pointed out, these facts are in some cases evolving, and so we'll keep providing as those facts evolve. After hearing these presentations, I think you'll agree with me that trained and dedicated professionals, both military and civilian, are working hard and planning intelligently to protect our community. And a lot of planning and hard work is going into making sure that our men and women in uniform and our civilian healthcare providers are protected as much as possible, so hopefully none of them ever contract Ebola in the first place. If worse comes to worse and someone does contract Ebola, there are many barriers in place to prevent the spread of Ebola, as we heard tonight. So it's an honor to live in a community which demonstrates such a commitment in this community to our health, our safety, and our national defense. Thank you all for being here.
Thank you, Congressman, and thanks everyone again for coming tonight. The presenters, some of them will be available to answer one-on-one questions and to speak with the media present. Please don't forget to stop by the information table on your way out. And if you're looking for digital resources for public health, visit www.elpasocountyhealth.org. Thank you and have a pleasant evening.